Well, good evening, all, and welcome to the Wednesday evening webinar. I think we're going to have a very interesting webinar this evening with three of our recent senior registrars who have undertaken or are, in one case, still undertaking fellowships abroad. And they are Jarlath Bulger, who's in Toronto General at present, Eamon Francis, who is in Newcastle, but will talk to us about his experience in Taiwan, and Elaine Redmond, who's back in Cork, having undertaken fellowships in Edmonton and Vancouver in Canada. I hope that you all have had the opportunity to listen to the Millen lecture that Joe Buckler gave last Friday, and it just gives you a sense of really how good our training in Ireland is, and how, when our trainees go abroad, how valued they are and how successful they are. Indeed, it was really nice to be back in the college, and we're hoping that we will have face-to-face charter meeting on Friday, the 22nd of April. The charter meeting was moved, but we kept the Millen meeting because the Deputy Secretary General of the UN was traveling to give the Carmichael lecture. And again, I hope many of you have had the opportunity to see that. And if not, I believe we'll be able to put a link up to it on the RCSI website. So the house rules are, many of you will be familiar, that please turn off your cameras if you're not speaking. And also please do mute your speakers if you are your microphone if you're not speaking. Please use the chat function to put any questions you might have that we can use at the end, because we will have time for a discussion. And I think particularly for senior registrars who are thinking about going abroad, this is a very important opportunity to ask questions of Eamon and Elaine, and I'm sure they'll be very happy to enlighten you. So with those few words, can I ask Catherine if you would be kind enough to start the ball rolling with Jarlath Bulger's presentation? Thank you.
First off, thanks to the President for the invitation to contribute to this webinar. I'm sorry I can't do it live and in person, but unfortunately we have an operating list running at the same time. My name is Jarlath Bulger. I'm the RCSI Collis Fellow, undertaking an upper GI fellowship in Toronto, Ontario. I've been asked to speak a little bit about my fellowship experience to date, a little bit about how I set things up, and any lessons that I've learned so far. So this is where I'm currently working, Toronto General Hospital, which is one of the major hospitals of the University Health Network, composed of Toronto General, Toronto Western, Princess Margaret Cancer Centre, and the Toronto Rehabilitation Institute. And this looks all nice and shiny and sunny, but this is what it actually looks like at the moment. We've had some pretty severe snowstorms over the last month or so, and some pretty freezing temperatures. So we're currently adapting to that and learning to live with the cold. In terms of what I'm going to talk about, first off, just a little bit about my own training pathway, what I thought about when trying to get a fellowship, how I went about setting it up, what they considered about me, what I've done to date, and any advice that may be helpful for people who are trying to set up fellowships going forward. So my training pathway was pretty standard. I graduated from RCSI in 2009. I undertook my internship in Beaumont and then went on to a PhD in surgery under the supervision of Professor Arnie Hill and Professor Leonie Young, which was really in translational oncology. I went on then to do the basic specialist training, do my memberships, and then do the higher specialist training scheme from 2015 to 2021. And I attained my FRCSI with the general surgery upper GI subspecialty interest in 2020. Thankfully, just before COVID started playing havoc with everything. But I think on this slide, the most formative experience for me in many ways was my PhD. And this really, although it started out as a master's and then morphed into an MD and eventually a PhD, this really kind of lit an interest in me in translational oncology and looking at the molecular mechanisms behind some of the diseases that we treat surgically. Other things that I was happy or fortunate enough to undertake were some robotic training, including being one of the first trainees to get access to the dual console system in Limerick, setting up the Irish Surgical Research Collaborative alongside my colleagues Helen Nolan, Christina Fleming and Michael Boland, and being involved in the Atlantic Surgical Leadership Program, which was a good opportunity to do something outside my comfort zone and think outside the box. So things that I thought about when trying to set up a fellowship, well, some of the easy questions first, I suppose. What do I want to do? I knew pretty early on what I wanted to do in terms of subspecialty, so that narrowed things down. The next big question was, what sort of career path do I see for myself? You know, whether I want to be a full-time clinician with an interest in research, or whether I want to be someone who's got a foot in both camps and spends time working as a researcher and as a clinician. Personally, that was a pathway that I would like to pursue, and we'll see how that evolves over the next few years. And then in terms of fellowship, I wanted to figure out where I could go that had a good split between clinical and research activities. Lots of fellowships are really, intensive clinical years, with less focus on research, or their expectation is you publish one paper as part of your fellowship. But I wanted somewhere that would really facilitate me getting involved in the basic science research again. Other things then to consider, and I think this is really important, but what suits my family. For me, there was a number of considerations. My wife is also doing fellowship training. We already had one child when we were considering this, and we've subsequently had another one since we arrived. Where do we want to live in terms of quality of life? If we're going to be away for a couple of years, we want to have somewhere where we can have a good quality of life and enjoy ourselves. And what's accessible, and I think this is more important since COVID, because certainly we did look at Australia as well, but thankfully we'd already made our decision to come here when COVID started shutting things down, because even with restrictions on travel, I think getting home from Canada is probably a little bit easier than getting home from the Antipodes. So how did I go about pursuing things once I this set up, and do I have any recommendations? Well, the first thing I'd say is talk to others, and that's what I did. I spoke to mentors, I spoke to other people who were setting up fellowships, people who'd been away on fellowship. Where did they go? Would they recommend it? Even if people hadn't undertaken an upper GI fellowship, they would know what a centre was like to work in, and they might be able to recommend people who had undertaken an upper GI fellowship in that centre. I think it's really important to talk to recent or current fellows. If you know someone who's been through a fellowship, they're a good port of call. I was very fortunate that Paul Carroll was here. Paul, who's now a consultant over in Galway, he was here when I was considering applying, and was very helpful in terms of putting me in touch with people and explaining how the program worked. I think it's really important to get in touch with people early. I started really investigating this towards the end of 2018, thinking I had plenty of time before my predicted date of CCST, which was June 2021. Turns out I was actually probably a little bit behind the curve. Some of the places were, particularly in Australia, were already booked up until 2022. So if you're interested in somewhere, reach out early. There's no harm. If you can visit in person, I was invited to visit in February 2019. It was a really useful opportunity to meet the staff here, get to tour the facilities, talk about my goals, talk about what I want to do in terms of research. And I think it's really important to be honest, and tell them what you want to do and when you want to come. It was also a nice chance. We got to go and take part in their annual research retreat, a little bit outside of Toronto, and see a little bit of a different side of Ontario and socialize with people. And I think that was really a useful thing for me. So what do they think about me, and what do they consider? And I've asked them since. So there's a couple of things. First of all, I think in terms of reputation, Irish trainees are really seen as, wherever we go, as really well trained and experienced by the time we come out of HST. We're seen as people who are capable of managing, complex workloads, managing complex patients, and whose operative skills are very good. The other thing then is personal recommendations. There remains a lot to be said for someone who will pick up the phone and say this trainee is really good, or, I think you would benefit from having them in the program, or they would benefit from being in your program. I was fortunate, as I said, Paul was very kind to me and put in a good word, but other people who've been to Toronto on fellowship also recommended me to the institution, which I think was helpful. In terms of getting down to brass tacks, then what they looked at was, well, number one, did my career goals actually what I told them actually match my CV? I as someone interested in academic surgery, have you actually got the CV to back that up? Had I got a track record in publishing? What could I actually contribute to UHN? And certainly this is an institution that is very heavily focused on the surgeon scientists and people having a research profile. So it wasn't just, can I come and do the ward rounds and contribute to the operative side of things, but can I actually contribute in a research setting as well? And I think they were looking for flexibility and adaptability as well. Obviously, I'm working outside of my own declared specialty, just because things are run a little bit different over here, but they wanted someone who could slot into that and wasn't afraid of getting out of their comfort zone. So since I've been here, what are some of the things that I've done? Well, since July, my time has really been split 60% research, maybe a little bit more research, and about 30-40% clinical. What that looks like is that before Christmas, I was doing maybe 3 to 4 sessions operating a week. There's been a reduction since Christmas COVID, so we tend to do 2 sessions a week, sometimes 4 sessions a week, but 1 or 2 major sections a week. I usually do 1 session of endoscopy. I have very, very occasional and light clinic commitments, and certainly not even every week. I've done 24 minimally invasive mastectomies. We've done a number of colonic interpositions for benign and malignant conditions, which has been really good, as I'd only seen 1 or 2 of these over my 6 years at home. I have scrubbed on a variety of benign upper GI and thoracic cases. I've been leaving some of this to the other fellows and residents, particularly has been concentrating on the research this year. Heading off to do an MIS and bariatric rotation this spring. I've been doing some more robotic training, and UHN is the first entrant candidate to have the Medtronic Hugo system in place, so we've been training on that. And then for my second year of fellowship, planning to be a bit more heavy on the clinical side, probably about 75% and about 25% of my time dedicated to research, which will hopefully allow me to finish a lot of the projects that we set up this year. In terms of the research stuff, it's been going very well. I've had a few manuscripts of original work accepted already. We've got another couple that are kind of just ready for submission. 3 that are almost ready to go. We're setting up a clinical feasibility study of a perioperative intervention, which will hopefully lead to an RCT. And then the really nice thing for me is getting back to the scientific work, working with the esophageal organoid model, looking at predicting responses to neoadjuvant therapy and how we can use organoids as screening tools to try and alter patient care. So if I have any advice to people, well, I think consider your options early and cast a wide net. I don't think it's ever too early to get in touch with places and tell them that you might be interested. As I said, cast a wide net. You never know. Some places will have local trainees that they may have promised fellowship positions to. So even if you have your heart set on somewhere, the dates may not just line up. So cast a wide net and ask around and visit a few places if you can. Talk to previous or current fellows and read between the lines. No one ever says that they hated their fellowship, but if you kind of really ask people in depth, well, what are the good things, what are the bad things, you'll be able to see what really annoyed people about where they were or what they really liked and whether that would suit you. Once you have narrowed it down a bit, go and visit if you can. And don't be afraid of negotiating with places in terms of flexibility around certain things, maybe start dates, end dates, maybe what you want to do in your program. I think you're probably in a stronger position than you realize. Don't be afraid of working outside of what you're comfortable with. Consider where you're going in terms of quality of life and family. Be flexible and take things in your stride. Since I came here, one of the main esophageal surgeons here, Dr. Darling, has been headhunted and has now gone to be and left and taken up a job as the chief of surgery in Halifax, Nova Scotia, which initially I thought might set me back a bit, but has actually been a great opportunity in terms of giving me increased access to and more responsibility in terms of managing our patients and operative care. So this has actually, in some ways, been quite beneficial. Make sure you save and apply for grants. I'm very fortunate to be funded by RCSI. It certainly makes things a lot easier in terms of trying to maintain any sort of standard of living here. But if you can save up, fellowship is an expensive time. For a lot of us, we have other things going on in our life, like children, mortgages, all those kind of things, and everything is expensive. And certainly, I know people give out the cost of living in Dublin, but it is no better over here. I can promise you that much. So make sure you save up. You've got some sort of financial buffer and apply for whatever grants are available. So I'm sorry I can't be there in person to take part in any discussions, but if people want to pick my brains about anything, I'm more than happy to answer questions. I can be contacted via my RCSI email, which is jarbolger, jarbolger @rcsi.ie, or my UHN email, jar.bolger@uhn.ca. And once again, just thank you to the President for the chance to present and discuss my experience to date.
Good. Now, I hope I'm back online, seeing as how I'm very inexperienced at doing the mechanics of this, but I hope you all got to hear Jarlath's presentation. And we might move on and ask Eamon Francis if he could give his presentation now. Eamon?
So thank you, Professor O'Connell, and to the Royal College of Surgeons for the opportunity to speak about my fellowship, which was, as you can see, in Taiwan. And I was very fortunate to be the recipient of the Colley's Medal and the Travelling Fellowship in the year 2020. I can go to the next slide, Catherine, please. So for those of you who don't know where Taiwan is, it's all the way across the world. It's a small island situated in the South China Sea. The population is about 25 million, so similar to Australia from that perspective. But the physical size is half that of Ireland, so it's a very densely populated country. And Catherine, if you can just go forward on the next two, there you can see it. And I was situated in Taipei, which is in the north of the country and the de facto capital of Taiwan. And you can go forward again, please. So many of you recognize the structure. This is Taipei 101. It's in the shape of a bamboo, and it's their international financial trading center. And you can see downtown Taiwan. So it's a very large cosmopolitan city. And you can go forward again, please. This is CSK Memorial Hall. This is a very famous landmark. CSK was the leader of China and then subsequently Taiwan, and very different type of architecture. We can go forward again, please. This is one of the national palaces. We can go forward. And this is Longshang Temple, a very famous temple, which is situated just around the corner from my apartment. And go forward again, please. This is the national government buildings. Again, you can see the diversity in terms of the architecture representing its past in terms of its colonial history. We can go forward again. And then this is something a little bit lighter. This is Ximending, where I used to live. And this is the Times Square equivalent for those of you who know America, and Shibuya for those of you who are familiar with Tokyo in Japan. It's a very dynamic place. And this just, again, is a beautiful image showing Taipei lit up at nighttime as a really beautiful cosmopolitan city. And we can go forward again, please. So I was asked to talk about my fellowship briefly, the impact I feel it's had on my career, and then the advice I have for those looking to go on fellowship in the future. So we can just go forward again, please. So my fellowship, as I said, was in Taiwan in Jianggung Medical University Hospital. The fellowship itself was founded 30 years ago now by Professor Fu Chan Wei, and they take 6 international fellows per year. Typically 80 to 90 people apply. It now represents 72 countries internationally in terms of fellows, Ireland being 72 as of 2020. I was based in Linkau, which is a suburb just outside Taipei. So that's a 4,000 bed hospital with 90 operating suites over 2 stories. And it has a 24 bed microsurgical ICU, which is something very unique and novel. When you look at the alumni of the fellowship program, they are some of the world's most preeminent plastic surgeons and microsurgeons. In terms of volume, they typically perform greater than 1,200 free tissue transfers per year and up to 2,200. So really incredible volume. And they maintain the success rate of 98%, which is very much in keeping with that of the international literature. My fellowship supervisor is Professor Fuchan Wei. You'll see him on the far left. He's a very happy, smiling demeanor, which is very much representative of him. He was the subject of a Discovery Channel documentary, and he's literally written the book on reconstructive surgery and is a very much iconoclastic figure in plastic surgery, but in particular microsurgery, and a very humble and fantastic surgeon. And we can go forward, please. This is the front of the hospital for Changgung University outside of Linkou, and you can see for scale that they're all high-rise buildings on the hospital campus. Each building's 10 or 11 stories. And if you just go forward again, you can see from the posterior view, it's essentially like a mini city. And they've subsequently built two major buildings similar to those that you can see on site. The buildings incorporate travel agents, hairdressers, multiple different banks, McDonald's, everything you can possibly ever need that you don't ever need to leave the hospital. We can go forward again. My fellowship was organised after having a discussion with Professor Wei into 6 2-month rotations. I wanted to focus very much on head and neck reconstruction and limb reconstruction, which are very much applicable to home, and also learn lymphedema microsurgery and facial reanimation with the nerve team. We can go forward again. My first rotation was with Professor Yu Lin, who's a world-renowned hand surgeon who focused specifically on free toe transfer, venous flaps, and vascularized toe joint transfer for hand reconstruction. And he's also the chief of the department and a very lovely guy, and I got to do some really fantastic cases with him. And we can go forward again. My next rotation was with Professor Wei himself, which was an honor. Most fellows, or some fellows, don't actually have the opportunity to be his particular fellow. He's a world-renowned expert in the fibula and ALT flap, and also many other concepts and aspects of microsurgery, too much to actually list off tonight. But he is an encyclopedic knowledge of the literature, in particular of head and neck. And that's very much transferred upon to you as his fellow, where he expects you to read continuously outside of your operating hours, so you're up to date to have discussions with him and the team in relation to what's happening, what's new, what can we do. He also has a mini mantra that I picked up: never be careless. Mistakes come from carelessness. And that's really apt in microsurgery, where you have to really be focused continuously. My next rotation is with Professor Mingwei Cheng, who is a world-renowned leader in the field of lymphedema microsurgery. He also has a special interest in microvascular breast reconstruction. With him, I was exposed to super microsurgery, which is up to 80+ magnification under a special microscope for lymphatic or venous bypasses, and vascularized lymph node transfer, and also extracranial to intracranial bypass in conjunction with the neurosurgical team, which is something I hadn't heard of in Ireland prior to going to Taiwan in my training. And we can go forward again. And this is just some examples of vascularized lymph node transfer from the submental area to the distal wrist as a recipient, and the improvement you'll see after several months. And we can go forward again. Tommy Nai Chang is associate professor who works on the nerve team. And again, he's a specialist in facial reanimation, neurotization of microvascular breast reconstructions, and free function muscle transfer and nerve transfers for brachial plexus injuries. He's also the founder of the International Microsurgery Club, which holds specialist lectures every Saturday and Sunday with world-renowned speakers across the world. And the fellows are expected to participate in this and help moderate talks, which was a fantastic experience for me as well while being his fellow. We can go forward again, please. And lastly, I was going to mention Professor Luke Lin, who is the Director of Vascularized Composite Tissue Allotransplantation, the Chief of Trauma, and really a phenomenal surgeon who I learned so much from. You can see here an amputated limb, and this is a relatively rare occurrence. I had one throughout my training in Ireland, and we used to have approximately one per week in Taiwan, in conjunction with everything else, such as digital replantations, digital tip replantations, lower limb reconstructions. He's also a specialist in endoscopic assisted perforator flap dissection, which is a skill I've learned from him and hope to incorporate into my practice long term. And we can go forward again, please. And this is just some lower limb reconstruction and a spy camera looking at the perfusion of the flap on table. And we can go forward, please. So if I look at the impact of my career, I feel it's really been profound. I had excellent training in Ireland prior to embarking on fellowship. And I felt I was competent, but not confident. And really through this diverse, high volume exposure under the tutelage of experts, I really feel proficient in microsurgery and its applications, both in the elective and trauma setting. Taiwan is a very rich country and they very much embraced new technology and incorporate that into their practice as best as possible, both to make them a better surgeon, to have a better outcome from the patient, and ultimately to try and make it more cost effective for the healthcare system. Outpatients, while I don't speak Mandarin, was still very valuable. And I got to speak with patients who either spoke a little bit of English or through a translator. And I got to ask them very openly and honestly what they felt in terms of their reconstructions and any perceived advantages, disadvantages, and what they would like potentially to be different, which was interesting. From an academic perspective, I've been involved in multiple peer-reviewed papers with Changung, and some of them are currently under submission. I've been an invited reviewer for major academic journals in plastic surgery and for writing book chapters. And I've also gained a master's in reconstructive microsurgery, so a higher degree as part of my fellowship through the Changung University. I think two really important things I'll take from the fellowship are mentorship and the importance of teaching and training. Mentorship from the perspective that each one of these people mentored me expertly over my time with them. And there are people who I still talk to and can talk to at any stage in my career for subspecialty advice, which really is invaluable. And teaching and training, again, a lot of time is invested in me by both my mentors at home in Ireland and also my new mentors in Taiwan. And it's something I'm become very passionate about and want to very much bring forward to the next generation when I'm a consultant. And we can go forward again, please. I just want to briefly mention, we said we have 6 international fellows. There are now really 5 really close international friends from South Korea, France, Taiwan, America, and Sweden. And we all keep in contact. And we can go forward again, please. These are some of the junior attendings who I became extremely close with, and they went out of their way to make sure I got absolutely everything I wanted from the fellowship in terms of operating and in terms of research, and I'm really indebted to them for all their help, Jamie, Johnny, and David. And we can go forward again, please. And then just lastly, the residents. So the senior residents, we spent a huge amount of time together operating, but also they were extremely warm and friendly, much like the Irish. And we didn't just spend time in the hospital, but we went out to each other's homes to have dinner and went out to restaurants. And they are the next generation of microsurgeons in Taiwan. So I think I have lifelong links to that unit, which is really special. And we can go forward, please. And then very lastly, it wasn't all work. There are bank holidays in Taiwan as there are in Ireland and the United Kingdom. We got to do some traveling to Sun Moon Lake, Taroko Gorge, which are the touristic hotspots of Taiwan. And go forward again, please. And to the islands off the coast, which are really beautiful. And then my advice for people going in fellowship, well, I think you'll hear this from pretty much everyone. Choose somewhere where you wouldn't mind staying long term. I think with the uncertainty of consultant recruitment at home, you have to be a little bit savvy in terms of where you want to work and whether you have the opportunity to stay there long term. So consider that. Plan in advance. I think much like Jarlath said, many of the international fellowships are taken 12 or 1 to 2 years in advance of your proposed start date. So be cognizant. I use my annual leave to do observerships in places that I wanted to apply and wanted to visit. Yes, you can talk to people, but there's no substitute for physically going there. Also, you're not just a name on a piece of paper, you're a face, and hopefully they know you and like you. It will make you more competitive. Choose fellowships, obviously, that are recognised, but also look for something that maybe hasn't been done before. Bring back something new, something different. Don't follow the same path as absolutely everybody else. Make yourself some way unique. As Jarlath said, it's a very expensive time in your career. So save throughout your higher surgical training. I was very fortunate to be the recipient of some prizes from the Royal College of Surgeons, which allowed me to actually go to Taiwan. So I'm very grateful to them for that. So, but don't undersell yourself either. So put yourself forward for these. And then lastly, I'd say enjoy it. It really is one of the most exciting times in your career. There are moments where it's exceptionally challenging, but that's really character building. And you look back on that particular time very fondly. So thank you to everyone in the Royal College of Surgeons, Professor O'Connell and Professor Mealy, and especially to Padraig Kelly and Caroline McGuinness in the Department of Surgical Affairs, and Kieran Ryan, who've been fantastic to me throughout my training in Ireland. So thank you all.
Thank you very much. And just say there's some echoing there, so we need to turn off microphones if they're not being used. Just to say, Eamon, I'm just remembering ECIC bypass, which we did with Mr. Chowdhury in the Richmond in 1982 when I was an SHO in neurosurgery. So nothing's new.
Okay.
And he had me practicing with 10-0 nylon on rabbits using the operating microscope.
Well, it's a really
needless to say, it wasn't that successful. So I think maybe it'll come round again. But it was for people who'd had, I think it was called a PRIND, a potentially reversible ischemic neurological deficit.
Okay, well, yeah. But so for moya moya, it's a kind of an inherited weakness in the blood vessels that they get progressively narrowed. So it's for revascularization of that particular segment of the brain, and it's an endocyte anastomosis, which is technically even more difficult. So you're directly onto the gyri and sulci of the brain, and the vessels are less than a millimeter, as you've known, you've seen it. And it's not just based clinically, so it's all checked then intraoperatively with indocyanine green. So you look at the perfusion of the blood vessel to make sure it doesn't thrombose or leak, more importantly, in the contained space. So very, very interesting operation.
My goodness, right. Well, fantastic. So we move on, and Elaine, good to see you. Elaine Redmond has done fellowships in Edmonton, Alberta, and in my favorite city, Vancouver, BC. So, Elaine.
Super. So I'm going to talk a little bit about the two fellowships I did, but I also want to try and impart some advice for people that are trying to plan their fellowship. And we'll just go back to the first slide again, because I thought that this picture was particularly apt, because you're kind of a bit like this polar bear here when you come to the end of your training, because on one hand, you know, you're very well trained, you're like a big powerful animal, but it's also a very vulnerable time, because you're leaving everything you know behind, and you're taking a little bit of a leap of faith. You're not quite sure what the future holds, and you're just hoping that you land on a fellowship that's going to give you the right kind of opportunities to secure a consultant job wherever you want to end up. We'll just move to the next slide, which shows just a little bit about me. So I graduated from UCC in 2008, and I completed my surgical training in urology in 2019. And then I pursued two competitive fellowships. So the first fellowship was in reconstructive urology in the University of Alberta in Edmonton. And my second fellowship was in pediatric urology in BC Children's Hospital, Vancouver. And I'm currently a consultant urologist in Cork University Hospital. So why did I choose these areas? Well, I developed an interest in these areas early in my career when I was working with Hugh Flood in Limerick. So Mr. Flood had a mix of pediatric and adult reconstructive patients, and I quite like this area because generally speaking, these conditions aren't really life-limiting, they're more lifestyle-limiting, and there's not really an absolute need for surgery, and it's something that I really enjoy, getting to talk to patients about different treatment options, and then individualizing their care or personalizing kind of what's important to them, really. On the other hand, I also noted that there was a lack of reconstructive urologists in Ireland, particularly for urethral surgery. And I also spotted that there were a number of imminent retirements in pediatric urology regionally. So I felt that by specialising in these two areas that it would see me in good stead looking for job opportunities to come home. So my first fellowship was in reconstructive urology, like I said, and that was in Edmonton, Alberta, which is shown in the map there. This was an accredited fellowship with the Society of Genitourinary Reconstructive Surgeons, and it was gained through a competitive matching process. It covered the breadth of reconstructive urology in terms of urethral reconstruction, male incontinence, some andrology, female and neurourology, but my main mentor was Keith Rourke, and he was pictured in the bottom left there. He was my main reasoning for pursuing this fellowship because he's a urethral surgeon and performs one of the highest volume urethroplasties in the world. We'll move on to the next slide. So, as I say, the main focus of my my fellowship was in urethral reconstruction, and you can see in the picture on the left there, it's a picture of a urethrogram, and that hopefully shows quite an obvious stricture. And what that looks like endoscopically is, if you see in the top photo in the middle, that's a widely normally patent urethra, but with a stricture, you get a fibrotic narrowing that can scare down to a pinpoint. And these patients typically present with obstructive symptoms like reduced flow and difficulty voiding, and in severe cases can present with urinary tract infections or upper tract dysfunction and renal failure. Traditionally, the treatment will be to lay the stricture open endoscopically, but that is quite poor, and you only really get a sustained cure in about 24% of cases. So usually the patient is committed to repeated endoscopic interventions or a long-term catheter. There's a variety of different reconstructive options nowadays in terms of urethral reconstruction, and I'm very sorry about the background noise here. I hope you can still hear me, but that largely depends on the site and the location, the length of the stricture. And the picture that I've shown on the right there is dorsal onlay urethroplasty, where we take a buccal mucosa graft and patch that onto the urethra to repair the stricture. And we can move to the next slide. So my second fellowship was in pediatric urology, and that was in BC Children's Hospital. Typically, pediatric urology fellowships internationally are 2-year fellowships, and I really just only wanted to do a 1-year fellowship, and I was lucky that BC Children's are only in the process of applying for an accredited fellowship, so I was able to slot in there and do a 12-month fellowship. So that's in Vancouver, which is shown on the map there. And my main mentor here was Dr. McNeely, who's the outgoing president of the Canadian Urological Association and a world-renowned pediatric urologist. The pictures on the right are of the BC Children's Hospital building, which is a new build perhaps in the last 5 to 6 years, and it's modelled on the Children's Hospital in Melbourne, if anybody's been there. It's a phenomenal hospital they've built with expansion in mind, and in the emergency department there's actually a whole corridor of bays that aren't in use at the moment. They hope to extend in there in the next 30 or 40 years. We'll move on to the next slide. So one of the things that impressed me most about training in Canada was just their investment in capital structures and their kind of forward planning for expansion as the population increases. And this is the ambulatory care building in Edmonton. It consists of 8 floors, but actually 2 of the floors aren't currently in use. They're there just to expand into in the future. Our urology department occupied 1 entire floor, and that consisted of 4 outpatient suites, a lecture hall, a day ward, and 4 cystoscopy pods. And each cystoscopy pod consisted of 2 rooms with a doctor's writing room in the middle, and you could flip between the 2 rooms and get through a world of cystoscopic cases. One of the rooms in each pod had a hoist in the roof in case patients needed a hoist transfer, and also a C-arm which allowed you to perform procedures requiring X-ray, like in my case, ureterograms, or in the case of stone surgeons, the placement of stents. We'll move on to the next slide. The other thing that really impressed me about Canada was the ability to do high quality research. So both of the units had large prospectively maintained databases, and it really lends itself to having a high research output during your fellowship year. We'll move on to the next slide again. So my last few slides are just to impart some advice on people who are just trying to decide on what subspecialist field to move into. So you need to balance what your subspecialist interests are. So we'll move on this slide one. And you need to balance this with where the job opportunities are going to be. So to do that, you should, or to find out where the job opportunities are likely to lie, I would consult the model of care for your subspecialist field, and also talk to your mentors. And as Eamon alluded to, if you're interested in working in a particular unit when you come back, I think you should make your intentions known with them. So it's unusual to have a firm job offer before you go on fellowship, but it's no harm throwing your hat in the ring and sounding things out and seeing if there is going to be a job opportunity in that particular department. We'll move on next. So when you're deciding on your subspecialist field, just try not to pick a fellowship that has a really narrow focus. You know, you don't want to be a one-trick pony coming home. You want to have a couple of feathers to your bow. And similarly, be cautious about choosing a fellowship that's oversubscribed, because you may find that your job opportunities are limited when you come home because you're applying to very competitive subspecialist fields. We'll move on again. So once you decide which subspecialist area you want to specialise in, make a short list of potential fellowship options. Subspecialist societies are a really good resource because often they'll be associated with affiliated fellowships, and their websites can be a wealth of resource in terms of application policies and deadlines. I'd also reach out to renowned surgeons in the field, and because often they will have their own fellowship programs attached to their service. Talk to consultants and previous SPRs who've done similar fellowships. We'll move on again. And then in setting up the fellowship, you need to familiarise yourself with the application process and deadlines. Particularly as an international applicant, you need to specifically clarify that the fellowship will accept an international application and that has funding for an international fellow. You also need to check the exam requirements in terms of working in that institution. I would email the fellowship director and key stakeholders in the fellowship program, initiate contact early and often, and try to meet with these people in person at meetings if feasible. You also need to be aware that the fellowship director is going to try and put the best face forward for the fellowship and is going to minimise any negative aspects to the fellowship. So you really need to be aware and email previous fellows. And as Eamon mentioned, it's important to visit the unit to see that actually that the fellow is getting to do what the fellowship director says the fellowship entails. And then finally, search for recent research output from the institution if this is something that's important to you. And we'll move on. So fellowship-specific considerations. So you need to consider, is it valuable to do an accredited fellowship? Certainly, if you want to stay in North America after your fellowship, that is very important. I also liked the idea of doing an accredited fellowship because you know that it's affiliated with a particular society and that the fellowship program is kind of duty-bound to see that you reach your goals in the fellowship. You also need to consider the reputation of the unit. I knew that I was going to a unit with a very good reputation that had renowned surgeons operating there. You need to consider the overall surgical volume of the unit, but also your own operative time, and specifically your operative time as the primary operator. In North America, in some programs, they will hold the chief in higher regard than the fellow. So the chief will choose what cases they want to do, and you may get assigned to what's left over. You also need to consider the team structure, because sometimes there might be more than one fellow or more than one chief in competition with you for the big cases. I was really lucky. I was operating 4 days a week. I was the only fellow in both of my fellowships, and I was generally supported by junior residents, so they weren't competing with me for operative experience. You need to consider the breadth of operative experience that you're going to get. As I already alluded to, you don't want to come home very specialised in one specific area and not having the breadth of that subspecialist area. And also what research opportunities are available if that's something that's going to interest you. Some considerations that get overlooked are family. So if you have a spouse, are they going to, or family, are they going to travel with you? Are they going to work remotely? Are they going to try and get a job locally, or are they going to take a sabbatical? And then in relation to children, if you plan on having children, are you going to have children before, during, or after your fellowship? My wife had twins when we were in Edmonton, and I was very lucky that we qualified for healthcare from the moment that we landed. But similarly, I know people who've gone on fellowship to Australia, and even something as simple as blood tests they've had to pay for. So that's something important to bear in mind. And then in relation to childcare, who's going to look after your children, it can be really difficult to get into daycare and schools, certainly in North America at least. So you need to start trying to set this up as early as possible. Next slide. So that needs me nicely onto funding. As Eamon and Jared alluded to, fellowship is a really expensive undertaking. Your salary as a fellow is generally less than an SPR salary. We're really fortunate with the RCSI supporting fellowship training in the form of grants and scholarships. It's important to familiarise yourself with these scholarships and the deadlines, and to, of course, apply for them. But it needs to be said that we're sending a lot of fellows on fellowship training every year. Everybody's applying for these grants and scholarships, so it's important to do your own saving as well, and not to solely bank on getting any of these grant opportunities. We'll move on to the next slide. And then finally, whatever subspecialist area you decide to specialise in, you're probably going to be able to find a fellowship opportunity to suit you in any major country or city in the world. So, pay consideration as to where that you'd like to live for a year or two. And I've been very fortunate to spend 2 years in Western Canada. It's a beautiful part of the world, and we've really enjoyed travelling around there during our time in Canada. And we'll move on to the next slide. So just in conclusion, when deciding on a fellowship, you need to balance your personal interests and future job opportunities. You need to plan early, initiate contact, note application deadlines, do your research, email previous fellows, visit the unit, and start saving. And then on the next slide, just above all, just have fun. If the ice breaks, if things don't pan out, just remember that you're a powerful polar bear. You know how to swim, and things always seem to work out the way they were supposed to in the end. So and now on my final slide, I'm happy to take any questions, and here's my email if anybody wants to contact me about my fellowships in more detail.
Wow, Elaine, you seem to have had a fantastic time, and well done. I'm going to start the discussion, and maybe if Eamon can come back in on camera and remind everybody that if you want to put a question, please use the chat function, and we'll see what we can do. You approached it from slightly different aspects. Eamon, you just wanted to get to this place that has the world's biggest experience in micro reconstruction and revascularization. Elaine, you wanted to really get experience that would make you the best person for the job that you wanted to get. I think they're both valid. Eamon, what do you think of the view that perhaps a proleptic appointment and sending somebody abroad to gain skills that are required by a department might be a better way of doing it? Or do you think you just look at the stars and go where your ambition takes you?
I think it's an extreme luxury to have that opportunity whereby you're prospectively appointed to go away and learn a particular skill. It's certainly much less stressful on you as a trainee and as a fellow if that's the case. The way I did it, there was, you always talk to your mentors at home and you have an idea, you have, some conversations about what particular types of jobs are going to become available in the future. Ultimately, as I mentioned in my talk, consultant recruitment, you have to be a little bit savvy, but you also have to be very, cognizant that, mightn't work out for you. So you have to get the best possible training, wherever that may be for you, whether it's in Asia or North America or anywhere. So I think ideally, I think that's in the ideal world, it would be lovely to have a consultant appointment, go abroad, learn a skill and come home to that particular job. I don't think that's the way it is working in Ireland for the majority of people going abroad on fellowship. Hopefully that will change in the future. I think that would be a very useful thing for people, actually.
Well, can I put it to you both, though, that you've both learned skills that unless you have come back to a position where you have the volume and opportunity to maintain those skills and build on them, you'll lose those skills. Elaine, what now that you're back, what do you think?
Yeah, I completely agree with that. Obviously, you don't want to subspecialize in something that is very rare, unique, and will have a low volume. Happily, since I've come back, I've been overwhelmed with referrals for men with strictures, incontinent men, and a particular interest of mine with regards to pediatric urology is hypospadias, because in essence that's also urethral reconstruction. So I've been very fortunate from that perspective. And just to kind of touch on Eamon's point, I think whatever way you go about deciding what fellowship you go on, ultimately, even though you can say in one respect that we came at it from different angles, ultimately you end up in the same point, because you decide what area, perhaps at home is lacking, and then you decide who is the best person in the world that I could go to, to learn this from. So I think in essence, we've both ended up in similar fellowship paths from that perspective.
Is it a question of seeing what new technology is on the horizon, be it robotic, image-guided AI, and going to be the person to bring that back, do you think?
I think that's a little bit of a double-edged sword, because new technologies are generally very expensive, and I think if the technology doesn't exist in the institution you want to come back to already, it may be difficult to get that equipment there. And I know that for myself, even just me wanting to order very basic microdissecting instruments, it has taken time, because there's red tape, there's an application process for all of that.
Yeah, I agree. I think it's really important to embrace new technology, because it does have advantages for you as a surgeon, your ability, and also will translate benefits to the patient, hopefully, and the healthcare system. But it can be very expensive, and I think you have to show a cost-effective analysis for that to introduce it, and that's the difficulty in any healthcare system, no matter where you work. You can look at existing technologies that are available to you. For instance, endoscopy is pretty common in most university hospitals. It's not something that's commonly used by plastic surgeons, but there is a role for it. And again, you can adapt existing technologies and try and use it. They're using the Da Vinci robot in Taiwan to raise certain types of flaps off license. So I know the robot is available in certain centres in Ireland, but it's primarily used by a urologist, as far as I'm aware. And I got some experience with it abroad. But again, to buy a robot is a huge capital investment by any hospital, and then how to introduce that, again, is something very tricky to do. But new technologies will come forward undoubtedly in the future.
Do you think there's a role for what they call the TIG fellowships that are in the UK? These are these trans-specialty fellowships, and I'm particularly thinking, Eamon, in plastic and aesthetic and reconstructive surgery of breast oncoplastic type fellowships. I mean, this would seem to me to have a much more translational application than going to acquire a particular new skill.
Yes and no. There's a huge amount of debate about that at the moment, and it's a political hot potato, as they say.
That's yeah. I see you smiling there because that's exactly why I brought it up.
Yeah. So with breast that you mentioned specifically, there is not going to be a breast TIG, as far as I'm aware, for 2021. There are issues with it. I think certain specialties benefit more from it than others in terms of reciprocation. So in the United Kingdom, there is hand, head and neck, and breast. And there are lots of skills to be used. For instance, the head and neck TIG, which I've experienced with, you do the resection and the ablation as opposed to the reconstruction primarily. So then when you come home as a consultant, or wherever you end up as a consultant, then you need to have the referrals for that. And the referral pathways mightn't exist for that at the moment. So for instance, if you're going to be a plastic surgeon who does oncoplastic breast, will you collaborate, or will your colleagues at home collaborate with you and give you people in an oncoplastic setting? And that's something you need to really discuss with them in detail, I would suggest, before embarking on that type of fellowship.
Very politically correct, Eamon. Well done. Can I ask you both, how do you feel when you went abroad? How do you feel that your Irish surgical training stood you? Did it stand you in good stead, Elaine?
Yeah, completely. And I think Jarlath touched on that. I think internationally, our surgical training program is fairly renowned. You know, I think when fellowship directors accept you on their fellowship, they expect that you're like other trainees before you, that you're able to operate. You know, and that really your fellowship is just applying the surgical skills that you already have to perhaps a different kind of operation that may not be available in Ireland, but that the skills are there for sure.
Yeah, I would agree fully. So when I look at my group of 5 people, so the 2 Americans, one had just finished a fellowship in the Mayo Clinic, the other had finished a fellowship in Emory. Olivier from France had come from Gustave Roussy, which is one of the most eminent hospitals in France. Eleanor was from Uppsala, which is one of the biggest units for microsurgery and plastic surgery in Sweden. So as a group of people, we're all exceptionally well trained by our local units going abroad. So I think we had a high level starting, but you know, there's a huge curve with any fellowship from where you start to where you end up. But I think we all started in a very strong position. So I think as Irish trainees, and I can see for myself, comparing myself directly to other people, we all started pretty much at a similar point.
Oh, that's good to know, and it's the wonderful connections that you have now made, Eamon, that will stand to you for the rest of your career. I mean, these are people that you will interact on an international stage with for years to come.
Yes, you know, I completely agree, and that was one of the really highlights about the fellowship that I didn't necessarily appreciate before I went, in terms of there's such a strong bond that you actually make with your co-fellows. Especially, you know, we were involved in the pandemic, Elaine and I, in terms of going abroad. My family weren't allowed to come and visit me. I wasn't allowed to leave and come home. So you're very much on your own. So your co-fellows became your family, and you spent a huge amount of time together, both in work and socially. So we have a very strong bond.
And Elaine, what did you think of the Canadian healthcare system in terms of its funding and accessibility?
Yeah, it's great. I mean, we obviously accessed as a patient, and then I experienced it working in the system as well. You know, so it's a free from point of service. And the way the hospitals seem to be structured over there is, you know, you have these major academic centres in the major cities, and these are really, really high volume centres with kind of cutting edge technology, and then outside of the major cities, there are more community hospitals and community urologists, and I don't really have any experience of that, but the sense that I got was that their practices were a little bit less regulated than perhaps here in Ireland, in that you might have people doing very low volume prostatectomies or cystectomies, or whatever the urologist felt comfortable kind of doing themselves, whereas I think here in Ireland we have a little bit more tightly regulated practices, so that's I guess a positive and a negative rolled into one, maybe.
How do they train for people in, if you like, Kamloops or Victoria or somewhere like that?
Actually, a lot of the residents coming off, the various urology training programs nowadays can find it difficult to get jobs in the major academic centres, and a lot of their plans are to work in the community. And because their salaries are generally a fee for service, those community jobs can actually be really, really competitive because they're quite lucrative. I guess one of the difficulties when you're working in more remote areas is that you're probably not going to have residents. Your assistants are maybe GP assistants. They have GP anaesthetists as well, who've come through GP training schemes and then gone off and done a couple of years as anaesthetists, so maybe your backup isn't quite as strong as you might have in the academic centres, but yeah, certainly those community urologist jobs appear to be quite lucrative.
Last question is, how much difference did the Collis fellowships or funding make? Was it really the difference between being able to do it and not, or did it just give a comfort factor?
Well, I think for me, my fellowship is unsalaried, and that's the way it is for everyone who applies to go to Changung, irrespective of which unit you come from internationally or who proposes you to go there. So the fellowship was fantastic. It was hugely influential and important for me to go, for sure.
For me, I had a basic salary that wouldn't really have covered my cost of living, so yeah, the grants certainly did help me as well. But ultimately, I think, there's an expectation to be competitive and that you're going to go on a fellowship irrespective of the cost. But it was certainly nice to be able to break even coming home, maybe, instead of coming back in debt.
Well, certainly I remember all those years ago, the Trinity College or Dublin University travelling scholarship made the difference to get my wife and I out to Mayo to do a year's of research. Then I got the clinical fellowship, but it was transformative. The experience of living abroad, working in a different system, and you actually come back, I think, with a different view, and you see the good and the bad, but you also understand that there's good and bad elsewhere. And I think you're actually more mature and able to work in our system if you've been abroad working, as opposed to just visiting. So I think we've just passed 7 o'clock. I think we've had really a very interesting discussion this evening. And I'm sorry Charlotte couldn't join us, but clearly he's doing more important things operating this afternoon. But I congratulate all three of you on your achievements. You are certainly standard bearers for Irish surgery when you go abroad, and you'll be pleased to know that the standards that the year behind you that we've just awarded Collis fellowships for is, if anything, better than you were. So there you go. So thank you all, and as always, thank you to Catherine and Porrick and all the team, and the Vice President Laura Vianney, who organises these Wednesday afternoons. I just turn up and do compare from time to time. So I do very little work, and thank you all. I hope everybody enjoyed it, and we'll see you in a fortnight.
Thank you very much.
Thank you.